Today we'll discuss the disorder of the urinary bladder. So the urinary bladder, as you know, it is a muscular structure, muscular sac, lined by transitional epithelium and covered or coated by the three muscle layer, and also enveloped by the serosa. The function of the urinary bladder, it is the storage or reservoir for urine until there is a suitable situation so the patient or the human being can pass urine. The capacity of the bladder different from one person to other. The first sensation of the fullness of the bladder is occur at the 180 cc, and the third occur at 350. And as I said previously, it is different from one person to other. In this lecture, we will discuss the congenital and the acquired disorder that occur in the urinary bladder. So at first, we divided it into two parts. Either it is congenital or acquired anomaly. At first, we discussed the congenital, the ectopia vesaici or bladder exstrophy. The ectopia vesaici or bladder exstrophy. Exstrophy of the urinary bladder is a complete ventral defect of the urogenital sinus and the overlying skeletal system. The lower central abdomen is occupied by the inner surface of the posterior wall of the bladder, whose mucosal edge are fused with the skin. Urine spouts onto the abdominal wall from the urethral orifice. The rami of the pubic bone are widely separated. Epispadias almost always accompany it. Many untreated exstrophic bladder reveal fibrosis and chronic infection, and then convert to adenocarcinoma. Renal function and hydronephrosis caused by uretrovesical obstruction treatment, usually accomplished by surgical repair as early as possible, 1 week of life. How in this case present to us? 1 or 24 days, or some said you are as a rotator sitting in the nursery care, and there is an infant coming from the with family, said there is a patch, velvet color patch in the lower abdomen, and there is a spot of urine on the anterior abdominal wall. So it is a case of ectopia vesaici. A case of ectopia vesaici. What the function or the horrible function that should the doctor then only put a wet gauze on the area and call the urologist. Ectopia vesaici syndrome because there is multiple defects occur. Defect in the anterior wall of the bladder, defect in the anterior abdominal wall, separated pubic rami, and also epispadias. Epispadias, it means the opening or the urethral meatus located dorsally. The urethral meatus located dorsally. It is associated with ectopia vesicae. If this patient or this infant neglected by family, it leads to fibrosis and damage of the bladder tissue, and also there is suspicion or to conversion to adenocarcinoma. The second case, it is the persistent. Embryologically, the allantoids connect the urogenital sinus with the umbilicus. Normally, the allantoid is obliterated and is represented by a fibrous band called the urachus, extending from the dome of the bladder to the navel. Urachal formation is directly related to bladder descent. Lack of descent is more commonly associated with patent urachus than with bladder outlet obstruction. Incomplete obliteration is sometimes occur. If obliteration is complete except at the superior end, draining umbilicus sinus may be noted. If the inferior end remain open, it will communicate with the bladder, but this does not usually produce symptoms. Rarely, the entire tract remain patent, in which case urine drain constant from the umbilicus. This is up to become obvious within a few days of birth. If only the ends of the urachus seal off, cysts of that body may form and may become quite large, presenting a low midline mass. Adenocarcinoma may occur in a urachal cyst. Stones may be seen in a cyst of the urachus. Here appear the anatomical position of the urachus. The urachus is a band normally present in the intrauterine life. It is a canal or tunnel between the urogenital sinus and the navel. During the after birth, it should be closed and fibrosed, but sometimes for any cause, either closed from one side and remain open from the other, so lead to enlarge its size, follow the urine, sometimes infection, sometimes stone formation or a cyst, and sometimes the patient at any age may come with the drainage of pus or urine from its navel. Treatment consists of excision of the urachus, which lie on the peritoneal surface and bladder cuff. If adenocarcinoma is present, radical resection is required, unless other serious congenital anomaly are present, the prognosis is good. The complication of adenocarcinoma offer a poor prognosis. So, management, removal of urachus, open surgery, identify the urachus, separate it from the nevus, and then from the bladder, and from the bladder we should get a bladder cuff. So a part of the bladder is removed. It is called the bladder cuff. Sometime when we find there is an adenocarcinoma, as you know, the most common type of the bladder tumor is the transitional cell carcinoma. So the adenocarcinoma is considered a different and more serious condition. So it may need cystectomy to cure the patient. In spite of that, if we do resection of the urachus, it is considered a type or a case of a good prognosis, but if there is a complication by adenocarcinoma, it is have a poor prognosis. Acquired disorder of the bladder. Acquired disorder of the bladder. Interstitial cystitis or anal ulcer. Interstitial cystitis is a primary disease of middle-aged women, especially in women, but it may occur in men. It is characterized by fibrosis of vesical wall with consequent loss of bladder capacity. The patient comes with frequency, urgency, pelvic pain with the bladder distension are the principal symptoms. Pathogenesis. Infection does not appear to be the cause of fibrosis of the bladder wall because of urine is usually normal. The cause is still unknown, but the primary change is fibrosis in the deeper layer of the bladder. The capacity of the organ is decreased, sometimes markedly. The mucosa is thinned, especially where mobility is greatest, as the bladder full and empty. Over the dome and small ulcer are cracks. In the most severe cases, the normal mechanism of the urethral vesical junction is destroyed, leading to vesico-urethral reflux. Hydrourethral nephrosis and pyelonephritis may ensure. Clinical findings. Interstitial cystitis should be considered when middle-aged women with clear urine complain of severe frequency and nocturia and suprapubic pain on vesical distension. There is a long history of slowly progressive frequency, nocturia, both of which may be severe. Suprapubic pain is usually marked when bladder is full. Pain may also be experienced in the urethra or perineum. It is relieved on voiding. Attacks of gross hematuria occasionally noted. The patient is tense and anxious. A history of allergy may be obtained. Physical examination is usually normal. Some tenderness in the suprapubic area may be noted. Findings or X-ray or radiological finding. Extraorography are usually normal unless reflux has occurred. Cystogram reveal a bladder of a small capacity, reflects into dilated upper tract, may be noted on cystography. Instrumental examination. Cystoscopy is usually diagnostic. The vesical capacity as low as 16 mol. The bladder lining may look fairly normal. Punctuate hemorrhagic areas and agglomeration. Differential diagnosis. Tuberculosis of the bladder, schistosomiasis, and a specific vesical infection. Treatment. There is no definitive treatment or management for interstitial cystitis. The therapy employed offered partial relief, but it may be completely ineffective. General or vesical sedative. Hydraulic overdistension. Hydraulic overdistension. Installation of dimethyl sulfoxide, damzo, into the bladder. Cortisone state or prednisolone. Antihistamine, heparin sodium, surgical management in a form of ileocystoplasty may be done to augment the vesical capacity. So, this is a very important topics. Most common occur in middle-aged women. No one knows the real mechanism of the development. A lot of women come complain from this, especially after a recurrent attack of hematuria, recurrent attacks of pain, suprapubic pain, discomfort, perineal pain, pelvic pain, feeling of suprapubic pain or discomfort from a small amount of urine in the bladder. Also frequency that occur may reach to 20 times per day. So come complain from these attacks, and when we try to diagnose this case, see the bladder reach to a smaller capacity, lost its elasticity or flexibility. It occurred because of fibrosis in the middle layer of the bladder, and also there is an area of ulcer. It is called the honored ulcer. When we enter by scope, see it, and as an area of ulceration in the bladder, especially in the dome of the bladder, and this area highly vascular and bleeding on touch. And the management of this case, it is not a definitive, but relieve the pain from the patient. Nowadays, we will use hyaluronic acid, a combination of multiple drug, and also the hydrodistension to distract this fibrotic area. Vesical fistulae. Vesical fistulae are common. The bladder may communicate with the skin, intestinal tract, or female reproductive organs. As you know, the fistula, it is epithelialized tract between two different mucous surface. So it's either between the bladder and the skin, between the bladder and the GIT or gut, between the bladder and the female genital urinary tract. The most common type of vesical fistula, it is called the VVF, اللي هي vesico-vaginal fistula. Most common type هي ال VVF اللي هي vesico-vaginal fistula. We know the causes of this type of fistula. The causes are also, the causes are as follows. A primary intestinal disease, like the diverticulitis, 50 to 60% patient with diverticulitis, or cancer of the colon, 20 to 25%, and patient with the Crohn's disease, 10%, primary gynecological disease, Russian necrosis following difficult labor, advanced cancer of the cervix, treatment for gynecological disease following hysterectomy, cesarean section, or radiotherapy for tumor, and also trauma. So this is the cause of the vesico-vaginal fistula. A clinical finding, vesico-intestinal fistula symptoms include vesical irritability, the passage of feces or gas through the urethra, and usually change in bowel habits. Signs of bowel obstruction may be elicited. Abdominal tenderness may be found if the cause is inflammatory. The urine is always infected. Cystogram may reveal gas in the bladder or reflux of radio-opaque material into the bowel. We bring Foley catheter, put it in the bladder, and they inflate the bladder by radioactive substance. So do cystography, push dye in the bladder, and then we see the dye reach the bowel. So it is as give a hint about the presence of the vesico-intestinal fistula. And cystoscope examination, the most useful diagnostic procedure, show severe localized inflammatory reaction from which bowel contents may execute. Catheterization of the fistulous tract may be visible. The installation of the radio-opaque fluid often establish the diagnosis. Vesico-vaginal fistula, which is the most common, vesico-vaginal fistula. This relatively common fistula is secondary to obstetric surgery or surgical or or radiation injury, or to the invasive cancer of the cervix. The constant leak of urine is most distressing to the patient. Pelvic examination usually revealed the fistulous opening, which also can be visualized with the cystoscope. Vaginography often successfully shows ureterovaginal, vesicovaginal, or rectovaginal fistula. Biopsy of the edge of the fistula may show carcinoma. This is a sign when we do cystography and the dye will reach to bowel. This dye go from the bladder through the fistula to the bowel. So there is a track between the bladder and colon. Treatment. Vesico-intestinal fistula. If the lesion is in the rectosigmoid, treatment consists of proximal colostomy. When the inflammatory reaction has subsided, the involved bowel may be resected with the closure of the opening of the bladder. The colostomy can be closed later. Small bowel or appendiceal vesical fistula require bowel or appendiceal resection and closure of the vesical defects. VVF. Tiny fistula opening may become sealed following the introduction of an electrode into the fistula. Very small fistula. We can do, if it is a tiny fistula, trans the urethra, reach the bladder, and then do catheterization around it, destruct the epithelium, as I said in the beginning, what the meaning of fistula. Tract with or epithelialized tract. So we will do destruction of this epithelium, with of a Foley catheter to decrease the pressure inside the bladder. It may held or sealed by this technique, by an electrode inside the fistula. Large fistula, secondary to obstetrics or surgical injury, respond readily to surgical repair. Fistula develop secondary to radiation therapy or direct extension by cancer are difficult to close. Non-infectious hemorrhagic cystitis. We go for non-infectious hemorrhagic cystitis. Some patients following radiotherapy for carcinoma or of cervix or bladder, cyclophosphamide using to control bleeding. Cystoscopic flagellation. The installation of 3.9 formalin is more efficacious. Sometimes patients come with hemorrhage, continuous bladder bleeding, maybe due to radiotherapy of carcinoma or cyclophosphamide. To control bleeding either by inside the bladder, find the site of bleeding, catheterize it or flagrate it, do catheterization or flagration of it, so stop the bleeding. Sometimes no benefit. So we try to do or the use of alum. You know, the alum is the in market could ship alum. Alum, we will installate it inside the bladder by dilution by normal saline and try to wash the bladder by it. Sometimes it benefits. If no benefit, go for the other things. It is in the installation of the formalin, which is a very painful. And if no benefit, we do internal iliac ligation. And if no benefit, we will do cystectomy. Inflation of balloon inside the bladder, embolization of the internal iliac artery, continuous irrigation with 1% alum solution to reduce the incidence of the cyclophosphamide-induced hemorrhagic cystitis. They produce diuresis and patient void frequently. Okay, last, I will remember you about the way or surgical way for management of the vaginal fistula. 3-way. If it is a tiny and small, we should do filtration or destruction of the epithelium of the tract, or surgical repair. And the surgical repair, either the transvaginal way or the transabdominal way. By transvaginal way, we should separate the vagina from the bladder at the side of the fistula, and then resection of the fistula, and after that we should use the Marsh flap or omental flap to separate between the bladder and the vagina. And when we do a closure of the bladder, we should not put the close a suture over other. So close the bladder in lateral way and close the vagina in the longitudinal, in the transverse way, and that on the vagina in the longitudinal way. Okay. Not put the stitch over the other. Transabdominal way for closure of the bladder. It's by 2 ways, either by O'Connor or Mandy. Either O'Connor or Mandy. O'Connor inside the bladder, and then separate the vagina from the bladder, and then remove or distract the fistula, and then close the vagina, put the flap, and then close the bladder. The other way, it is by longitudinal resection of the side of the fistula, complete separation of the bladder, longitudinal resection, removal of the side of the fistula, closure of the bladder, and then put a mental flap, and after that closure, close the vagina and put the mental flap, and put the drain and go away. Okay, this is the lecture about the bladder disorder. من عنده سؤال؟ من عنده سؤال؟ من عنده سؤال؟ وين سادين موبايلاتكم رايحين؟
سلامتك دكتور،
موجودين.
وين موجودين؟ ما حد موجود. ثم انتوا ليش حضوركم قليل؟ ليش 40 واحد داخلين بس؟ يعني حقهم النسائيه يشكون من عندكم. ليش ما تداومون؟ قاعد بالبيت وما تداوم؟ ليش ما تداومون؟ اكو واحد عنده سؤال؟ يلا اوكي. Good luck.